Alright guys, we're going to pick up with pulmonary embolisms. Pulmonary embolism is when there's some type of obstruction within the pulmonary arteries to where now blood is not able to circulate within those capillary alveolar, within the capillaries that surround the alveoli to allow oxygen to flow back and forth. Patients at risk for pulmonary embolism are those who have experienced long periods of immobility, such as those with heart disease and recent surgery, long bone fractures, or venous pooling associated with pregnancy, cancer, and DVTs, clotting disorders, and those who smoke are at risk of developing pulmonary PEs as well. These patients, when you go through your assessment, they will have a sudden onset of dyspnea and chest pain. They also will have possibly be bloody hemoptysis or bloody sputum within their cough, tachycardia, syncope. Make sure that you do lower leg assessment looking for DVTs. They may also have cool, moist skin or maybe anxious. During the late signs, they'll start developing cyanosis, hypotension, and distended neck veins as well. Treatment of a pulmonary embolism, is mainly monitoring the airway, keeping it open, and administering positive pressure ventilation. You want to monitor these patients for signs of respiratory failure, respiratory arrest, hypotension, or cardiac arrest, and immediately transport the patient. These patients, they will become hypoxic and go into respiratory failure very quickly if not treated appropriately. You can also have what's called acute pulmonary edema. This is often caused by some type of cardiac dysfunction. Now, pulmonary edema is the presence of fluid in the space between the alveoli and the capillaries that surround them, thus causing an interference within the gas exchange. You'll give me just 1 second. This will oftentimes result in hypoxia, and you have that fluid collecting between the alveoli and the pulmonary capillaries. So in a normal patient, O2 and CO2 is able to perfuse very easily. However, in those that have pulmonary edema, you have that fluid building between the alveoli and the capillary, thus not allowing oxygen to perfuse across that membrane to oxygenate the blood. Now, cardiogenic pulmonary edema, this is typically related to an inadequate pumping function of the left ventricle that drastically increases the pressure within the pulmonary capillaries, thus forcing fluid to leak into the space between the alveoli and capillaries and eventually into the alveoli themselves. So these patients, they'll be presenting with crackles because of that fluid within the lungs. So you want to make sure that you auscultate the lower lobes. They may be sitting in the tripod position, feel anxious and fatigued. They'll have pale, moist skin, cyanosis starting to set in. If they have swollen lower extremities or distended neck veins, you need to suspect cardiogenic pulmonary edema. That is due to something caused some sort of cardiac compromise. Also, if it's cardiogenic, they'll also be having a pink or frothy sputum because it'll be blood that's going across that membrane as well. Treatment for patients that are having an acute pulmonary edema will be CPAP will be very beneficial because it'll push that fluid out of the alveolar space. Now, if the patient does not fit the criteria for CPAP, deteriorates respiratory failure or arrest, or does not respond to CPAP administration, you must perform back valve mask ventilation with supplemental oxygen. Keep the patient in an upright sitting position as long as you can, because as long as you have them in that upright sitting position, all that fluid will stay down into the lower lobes, thus keeping as much of the alveoli clear as you can. Now, with spontaneous pneumothorax, um, a portion of the visceral pleura has actually ruptured without any trauma having been applied to the chest. Um, Gas exchange will be very impaired because now you have one lung that is no longer expanding. Risk factors of a spontaneous pneumothorax may include smoking, COPD, connective tissue disorders. Even patients who are tall, very thin, and cough too hard could cause a spontaneous pneumothorax. It's rare, but it is possible. Primary spontaneous pneumothorax, these occur in patients in their teenage years to early 20s who are tall and thin. That's what I was just talking about. It is thought that the reason these patients are more likely to suffer a spontaneous pneumo is that the visceral pleura is stretched within the chest cavity beyond its normal limit. Now, many victims of secondary pneumothorax also have a history of cigarette smoking or some type of connective tissue disorder, such as Marfan syndrome or Ehlers-Danlos syndrome. Secondary spontaneous pneumos also occur in patients who have a history of lung disease, such as COPD, and who are more prone to spontaneous pneumothorax from areas of weakened lung tissue called blebs or bullae. When going through and assessing the patients, they will present with sudden onset shortness of breath with no evidence of trauma. They'll have decreased breath sounds to the affected side. They'll be very tachypnic. You may find what's called subcutaneous emphysema, where air is actually collecting underneath the subcutaneous layer of skin. When you go to feel these areas, it'll almost feel like a snap, crackle, pop feeling, like you're running your hand over Rice Krispie treats. They'll have, or not Rice Krispie treats, but bubble wrap, and you'll feel that popping feeling. You'll also have the patient in the late signs. You'll also see cyanosis, O2 sat less than 94% as well. Treatment of a spontaneous pneumo, first thing is administration of oxygen to try to maintain an SpO2 of 94%. These patients will require positive pressure ventilation. However, CPAP is contraindicated for these patients, and you want to try to use the most minimal tidal volume necessary to ventilate the patient effectively. We don't want to put too much pressure in because it can cause that pneumothorax to deteriorate even more. With hyperventilation syndrome, this can be very difficult to distinguish between patients who are progressing through this due to the anxiety and respiratory distress due to a medical problem. So with patients that are hyperventilating, we do not want to withhold oxygen from the patient. Even if they have an O2 sat greater than 94, treat your patient, not the monitor. As they progress through the hyperventilation syndrome and carbon dioxide levels are continuing to decrease, they're going to become more excited, they're going to become more panicky, and they're going to start having muscle cramps. Usually they'll be in a very charged emotional situation. Some other symptoms that they may have, besides the spasms, they may feel dizzy or nervous, maybe have some chest tightness. But ultimately, our treatment for these patients is to try to calm them down and to get them to slow their breathing. Don't have the patient breathe into a paper bag or oxygen mask not connected to oxygen to allow them to rebreathe carbon dioxide. Conditions such as pulmonary embolism and myocardial infarctions can present similarly to hyperventilation syndrome, and that's why we don't want to place them, have them breathing in their carbon dioxide. These are two of the conditions in which, well, never mind. Ultimately, if you're unable to calm the patient and they continue hyperventilating, eventually they will pass out, and it's basically the body resetting itself. And usually once they wake back up, within a few seconds, they should be okay. Epiglottitis, this is caused by an infection of that epiglottis, that flap that seals the trachea, that ultimately causes an obstruction of the airway. Male patients and smokers are most commonly affected by this disease. Usually, as you're going through your assessment of patients with epiglottitis, they'll have a history of an upper respiratory infection that's usually been going on for about a day or two. These patients will also present with that high-pitched noise known as stridor, which is an indication of their airway almost completely occluded. They may also present with fatigue, cyanosis in the late stages. They may be sitting in the tripod position. May feel anxious and apprehensive as well. They may have a sore throat, so you keep an eye on, make sure that you do a very thorough assessment of these patients. For treatment of them, if the patient continues to deteriorate and requires assisted ventilations with a BVM device, squeeze the bag slowly, and this will help direct the air past the obstruction and into the lungs rather than into the esophagus, thus causing gastric inflation. If this is not effective in ventilating the patient, it is a situation of complete airway obstruction at the level of the epiglottis, and an ALS provider should be called to consider other advanced airway techniques. Pertussis, this is a highly contagious disease that these patients will have what's called a whooping sound when they cough, hence the second name of it, whooping cough. If it is allowed to progress far enough, it could eventually lead to death. Some complications of pertussis may include pneumonia, seizures, dehydration, brain injuries, and even and ear infections. Most deaths occur with younger patients who have not been immunized for this disease, or with those patients who have been exposed before finishing the vaccination series. Now, there are 3 stages of the recovery if those are going through pertussis that you need to assess for. During the first stage, these are when you'll have those common cold or upper respiratory infections. During stage 2, the coughing continues to worsen to the point that medical care is sought. Stage 3, or the recovery stage, is usually a gradual stage that takes several weeks. And depending on the stage that the patient is in, depends on what signs and symptoms that you will see. During the early phase, they'll have the runny nose and low-grade fever, but as it continues to progress, they'll start feeling more weak. They'll start producing that inspiratory whoop heard at the end of a coughing burst. Probably a pulse ox that is becoming very diminished, and even cyanosis during those coughing bursts during these later phases. Treatment of patients that are suspected to have pertussis, you want to place a surgical mask on the patients. That way when they go to cough, you don't risk them potentially contaminating other people. Once transporting a patient with known or suspected pertussis, you want to consider totally disinfecting the patient compartment of the back of your truck to ensure that you don't potentially contaminate any other people. Cystic fibrosis, this is a chronic disease, and often patients that are diagnosed with this are very young. It is a hereditary disease that causes a production of a very thick mucus that causes respiratory infections to occur very often. These patients will have, when they go to cough, they will be coughing up very thick mucus, abdominal pain, GI complaints, including diarrhea, and even foul-smelling bowel movements because of the mucus. May become dehydrated. They'll be very dehydrated. They'll have signs of pneumonia, as well as trouble speaking and breathing due to the mucus buildup. Treatment of a patient suffering from exacerbation of cystic fibrosis is geared towards symptomatic relief of the respiratory distress. So we're going to need to treat it based off the signs and symptoms. Usually these patients that are diagnosed with cystic fibrosis don't have a very long lifespan because of the mucus continuing to build up, that usually they end up unfortunately dying about the age of 23 to 25 years old due to pulmonary failure. Poisonous exposure. This is inhalation of toxins, which eventually lead to hypoxia by various mechanisms. Now, when a patient has been exposed to some type of poisonous gas, this does pose a risk to EMS personnel because, not every toxic gas can be seen. So you need to make sure that you are looking for signs that would lead you to a potential poison gas, such as birds dead in the area, vegetation that is withered. Patients will present with have upper airway swelling. Due to the gases that they've been exposed to, it may actually displace oxygen in the atmosphere itself. Certain gases will actually, when it enters, even may enter the bloodstream. It'll cross that membrane, enter the bloodstream, and it has a greater affinity of binding to your hemoglobin. So you can actually go and, put a pulse ox on these patients. They have a 96% saturation, but they're in respiratory failure. Well, the thing is, with carbon monoxide, it's one of those that has that greater affinity. So when you check a pulse ox, it doesn't necessarily can tell that it's actually oxygen. It just knows that there's something attached to that red blood cell. So those patients will also have some other signs and symptoms that you want to be aware of. So once again, treat your patient, not the monitor. When going through doing your assessment of them, you want to determine some things that will help determine how critical your patient is, such as how long they were exposed to it and whether or not they were in an open or enclosed space. If there is toxic gases still within the area, do not enter it. Let someone come in who has the proper PPE, such as the fire department, when they can put on their SCBAs and enter in that area. Treatment of patients that have been exposed to a poisonous gas because of the criticality of the patient or the potential for rapid deterioration. Try to arrange an ALS intercept en route to the receiving facility. Also provide early notification to the staff at the receiving facility so that it can prepare adequately for your arrival. Try to maintain a open patent airway with the patient, as well as giving these patients high flow oxygen to try to get as much back in and displace that toxic gases that they breathed in. Viral respiratory infections are commonly referred to as upper respiratory infections or URIs by the medical community because most symptoms are found in the nose and throat. In small children, however, viral respiratory infections can also cause infections of the lower airway structures, such as the trachea, bronchi, bronchioles, or lung. With these patients, you want to make sure that you assess and treat for both hypoxia and respiratory distress, because children can't compensate for respiratory issues as well as an adult can. So if you start noticing that the patient is starting to have issues with the respirations, be prepared to provide assistance through positive pressure ventilation. If there is the potential for deterioration, consider calling for ALS for administration of medications to prevent. Patients with viral respiratory infections may present with nasal congestion, tachypnea, malaise, fever, usually about between 101 to 102. Also, if the patient has asthma, this respiratory infection could cause exacerbation of it as well. Beta-2 agonists can be administered by either a metered dose inhaler or a small volume nebulizer to help relax the smooth muscle within the bronchioles. Metered dose inhalers are more convenient, but some patients use the nebulizers at home. Most bronchodilators begin to work almost immediately, and their effects can last up to 8 hours or more. Because of the swift relief they can provide, they are appropriate for pre-hospital administration by the EMT with approval of medical control. Now these are your metered dose inhalers. This is the one that most people are more commonly see, But with children, for some, this with a spacer attached to it as well is commonly more easier for them to use because then you can just place it over the patient's mask with just like a or BVM mask, spray the medication into the spacer, and then the child just has to breathe it in. Um, Make sure that you shake the medication very well prior to administration due to it being a suspension, and then have the patient inhale deeply, hold their breath for approximately 1 to 2 seconds before they let it out. With a small volume nebulizer, it'll either have a tube attached to it or some type of face mask with a chamber where you would actually place the medication into, and then an oxygen tubing that you hook up to the base. There are many respiratory medications that can be administered either through an inhaler or nebulizer, but not all are appropriate for emergency situations. Therefore, bronchodilators are only administered via physician order, whether it be online or offline. All of the following criteria must be met before you can administer a bronchodilator by metered dose inhaler or via nebulizer to a patient. The patient must be exhibiting signs and symptoms of respiratory distress due to bronchoconstriction. The inhaler or nebulizer must be prescribed to the patient by a physician, or a bronchodilator medication is carried on the EMS unit. Also, they have received approval from medical direction, whether online or offline, to administer this medication. A bronchodilator by an inhaler or nebulizer should not be given if any of the following conditions exist. If the patient is unresponsive, it is not prescribed to the patient, or is not within the EMT's protocol, medical direction has not granted permission, or the patient has already taken the maximum allowed dose prior to your arrival. Side effects of inhalers and/or nebulized treatments may include tachycardia, tremors, dry mouth. Now, this is associated due to the drug action itself, and eventually, once the medication has run its course, these symptoms will subside. Table 16-3 in your book goes over some signs of improvement that you would see during the administration of CPAP. Usually these patients will have a reduction in the complaint of dyspnea, a normal respiratory effort, as well as an improved SpO2 reading. Only a short-acting beta-2 agonist drug should be used in the emergency care of the patient experiencing an acute asthma attack. So if the patient has an Advair, do not use it for an emergency. This is a long-acting beta-2 drug. It does include a steroid, but this is used as a maintenance medication. Do not use it as a rescue inhaler. Now, y'all remember when we were going over anatomy and physiology about the various differences that a child has with the respiratory issue or respiratory system. Because of these different differentiations between an adult and a pediatric patient, the types of respiratory problems that a child has could be of concern because of the way the disease presents and the way patients respond to treatment. Respiratory failure for the pediatric patient is defined as inadequate oxygenation of the blood and an inadequate elimination of carbon dioxide from the body. Most common cause of cardiac arrest in a pediatric patient is what? Right. Due to some type of respiratory disease. Excuse me. Many of the signs and symptoms of breathing difficulty can be spotted as you form your general impression during the primary assessment. Labored or noisy breathing, and a child who is sitting up in a tripod position, lying limply or unresponsive, can be detected from the doorway as you walk in. Also, you want to look for clues that could help potentially lead you in. Is there any signs of trauma? Is there any medication lying around? You also want to start assessing the mental status as well as the airway, as well as the ABCs of your patient. Look for other signs of respiratory distress that would usually precede failure in an infant or child, such as an increased use of accessory muscles, flaring of the nose, severe anxiety, and tachycardia and tachypnea. Um, Also, when you start noticing that the pediatric patient is starting to use their intercostal muscle and retraction starting to set in, this is a very prominent sign that they're starting to go into respiratory failure. As they start progressing into respiratory failure, they'll start developing altered mental status. Their heart rate will begin slowing down and become bradycardic. Um, their head will begin bobbing as they become more fatigued. You'll start noticing cyanosis to the core. You'll also start noticing grunting and seesaw breathing, where the chest is drawn inward and abdomen moves outward, indicating extreme respiratory efforts. Care for the patient. Try to keep them comfortable. If they're with their caregiver, try to keep them with the caregiver to try to keep them calm. If their O2 sats are beginning to drop, apply supplemental oxygen. If the child is unable to tolerate an oxygen mask, have the parent hold it near the child's face. If at any time their breathing becomes inadequate, remove them from the parent. Open up that airway, make sure that you put some type of padding underneath their shoulders, and begin positive pressure ventilation. If they have some type of upper airway obstruction, if it was a sudden blockage and there was something around the child that could have been swallowed, and no history of other sign or disease, treat the patient for an upper airway foreign body obstruction. If the blockage came on gradually, the child has other signs of being ill, or they have a history of respiratory or other diseases, and no one saw the child swallow anything, avoid inserting anything into the airway. Instead, provide oxygen or positive pressure ventilation with supplemental oxygen as necessary. Reassess your patient appropriately. If they are critical, you want to reassess them every 5 minutes, non-critical every 15 minutes. Be prepared to intervene more aggressively if the condition deteriorates. With your geriatric patients, a lot of respiratory stress has many causes with the geriatric patients. The reason being is their respiratory functions already diminished, so they're not able to fight off diseases as well as they used to. Also, their chest wall is a lot less compliant in geriatric patients than they are in the average adult. Just like a pediatric patient, they also do not compensate very well for respiratory issues, so they progress very quickly from respiratory distress to respiratory failure. Many of the signs and symptoms of breathing difficulty can be spotted as you form your general impression during the primary assessment. Same as with every other group, you're going to look for tripod position, labored noisy breathing, unresponsiveness, and any other additional signs and symptoms as you contact the patient. Progress through your secondary assessment. The signs and symptoms of respiratory distress usually briefly precede respiratory failure in geriatric patients. Older patients do not have the compensatory mechanisms younger adults have, and they typically decompensate very rapidly. Look for those signs of breathing difficulty, such as the increased use of accessory muscles. You start noticing retractions, frequent coughing, nasal flaring, breathing with the mouth open. Go through your secondary assessment. If they have gone into respiratory arrest and they still have a pulse, all you need to do is you need to immediately intervene and provide positive pressure ventilation at the rescue breathing rate of 1 breath every 5 to 6 seconds. Care for the patient is try to keep, no matter what their age, try to keep them comfortable. The more uncomfortable they are, the more anxious they become. If they have an O2 sat less than 94%, or any sign of respiratory distress or hypoxia, provide oxygen via nasal cannula and titrate it to achieve an O2 sat of at least 94%. and then reassess en route to the emergency department as appropriate for the patient. When coming up on any patient that's in respiratory distress, you want to try to just following up with your assessment. Look for clues that could lead you to what's going on. Also scan the scene for signs of alcohol. This can often be a common contributor to patients choking and some type of upper airway obstruction due to aspiration of vomit. Go through your primary assessment, assess your mental status, assess your ABCs. At their mental status, you want to look for signs of restlessness or agitation. These are often correlated because with difficulty breathing, the brain is not getting enough oxygen. You also want to assess the airway and look for any signs or indications of complete or partial obstruction. Go through their breathing rate. Is their chest rise and fall equally? You want to auscultate the lungs, looking for any irregular breath sounds. And remember that shallow breathing is an indication of inadequate breathing. And keep in mind the ranges of concern for inadequate breathing. In an adult, a normal range is 8 to 24, children 15 to 30, and in infants 25 to 50. If your patient is breathing inadequately, you need to provide positive pressure ventilation. If they're breathing adequately, just administer oxygen to maintain an O2 sat of 94%. Go through circulation. Keep an eye on the skin. Look for signs of them becoming pale and cool, as well as cyanosis. Keep an eye on the heart rate, because as they become more hypoxic, their heart rate's going to steadily go up until they start going into respiratory failure, and the heart rate will start coming back down again. Any patient with difficulty breathing is a priority patient, and consider calling for ALS if you do have a patient with the difficulty breathing. Go through your secondary assessment. Go your OPQRST, also your sample history as well. Also, you want to determine if they have any hospitalizations recently for any chronic conditions, as well as any respiratory or cardiac problems. Table 16-4 goes over signs of deterioration during the administration of CPAP. I would recommend looking over this. If the patient becomes very speechless or the respiratory rate is continuing to increase, you may want to consider taking them off CPAP and getting prepared to give positive pressure ventilation via bag valve mask. Continuing on with your assessment, while you're going through your head-to-toe physical, you want to look at the neck for signs of jugular vein distension, which would indicate an extreme increase in pressure within the chest or venous system. Also, you want to check for tracheal deviation, as well as drawing of the trachea. If it is drawing inward during inhalation, that means that they may potentially have some type of pneumothorax starting to come into play. Also, you want to look for signs of difficulty breathing. Keep it on close eye on your vitals. Make sure that you auscultate the lungs. Make sure you look for all those signs and symptoms. And remember, the severity of shortness of breath does not directly correlate with the level of hypoxia. Even though a patient may present with what looks like severe shortness of breath, it doesn't necessarily mean that they're severely hypoxic with an O2 sat down in the 70s or 80s. If signs of inadequate breathing are present, such as poor chest rise and fall, poor volume, or inadequate rate, make sure that you have an open airway, transport expeditiously, and begin positive pressure ventilation. If they're breathing adequately, ensure that you have an O2 sat of 94%. If not, provide oxygen via an appropriate device to maintain an O2 sat of 94. Try to keep the patient in a position of comfort. If they have the indications for administration of their meter dose inhaler, you can administer that with approval by medical control. In cases of severe respiratory distress, if protocol allows, and the patient's condition is appropriate and indications are present, consider the use of CPAP. There are studies that show that patients in severe respiratory distress from a variety of conditions may benefit from CPAP. Go through and reassess your patient. You want to determine if anything that you have done has either caused an improvement or worsening of the patient's condition. If any changes has occurred, provide positive pressure ventilation. Monitor the respiratory rate, tidal volume, and closely monitor their heart rate and SpO2. Alright guys, that completes this chapter for today. If y'all have any questions, just shoot me a message in either Blackboard or Remind. I'll get back to them as soon as I can. Otherwise, I will see y'all next time in class.